please.
Yes, yes. So I'm so sorry for the glitch of network. So I welcome you all for this ACNS YNS webinar. And we've got, for the discussion, we've got Professor Fawad Pirzad, who's the Chief of Neurosurgical Society of Afghanistan, and Professor Alexander, who's the Chief of President of Neurosurgical Society of Ukraine, the two speakers for the discussion. Professor Federico Sale, who's the Chief of Neurosurgical Society of Uruguay, will be joining shortly. And for today's webinar, we've got two interesting speakers as the protocol and the theme of our webinar series. We've got one guest speaker and one YNS speaker. As a guest speaker, we've got Professor Christian Raftopoulos from Belgium. And as a YNS speaker, we have Professor Feng Zhu from China. And along with me, we have Dr. Chen from China as a co-moderator and Dr. Liu Bun Seng from Malaysia. So I welcome you all again. Before we start, may I request Professor Yoko Kato to say a few opening remarks, please. You are muted, Professor. You are muted, Prof. We can't hear you.
Welcome to the YNS webinar today. We are so honored to have the very important guest. One is from Christian, one of my best friend from Belgium, and the other one is very excellent YNS from Shanghai, Fudan Hospital, Dr. Xu. And also the discussant from one is from Afghanistan, and the Professor Pirzad. I'm so happy to see your face again. And also we are very honored to have the Society President of the Ukraine, Alexander. We are so happy to have both of you. So please start, Sachin.
Okay, so since we don't have Federico Sale so far, I would introduce our first speaker. So it's my pleasure to introduce Professor Christian Raftopoulos, who is the chairman and head of the Department of Neurosurgery at University Hospital St. Luc, UCL at Université Catholique de Leuven from Brussels, Belgium. And he's going to talk with us about cervical spine injuries in today's era. So may I request Professor Raftopoulos to please share his screen and start his presentation, please. You're muted, Prof. You'll have to unmute. Yes.
Wonderful. It was on your side. Okay. I'll share my screen. Do you see something? Not yet?
Not yet.
Do you see something?
Not yet.
Not yet.
We'll try again now. Sure.
Yes.
Yes. Do you see my presentation? Yes. Not yet.
Yes, we can see now. You can do the full screen.
Okay,
or
do it.
The power.
You see the full screen?
Not yet.
Christian, not yet.
What do you see now?
We just seeing the not full screen pattern. All the slides are there on the left side and the first slide on the center.
So slideshow, please.
Yeah, we can go for the slideshow.
Slideshow?
Yes.
It's okay?
No, not yet.
No, it's not yet started.
Your screen sharing is paused. Why? New share. No, wait. I will resume share. You see it?
Yes, we can see
yes,
your size, but it's very small.
Okay?
Not yet.
We can see a screen, but it's just a PowerPoint. The slide share or the play, you have to play the slide share. You can do the full
Yes,
screen.
I'll do it. And now?
Okay. No,
It's
okay,
okay?
let's do one thing. Maybe you can stop the share and share it again.
Okay, stop share.
Yeah. Now you
Share
can share it again.
Share.
Yeah,
good.
There you go. Now it's full screen. Perfect.
Okay,
Excellent.
so far. So I'm ready. I'm going to my presentation.
Yes.
Okay, so as you see, the topic of my presentation today is cervical spine injuries. And this presentation is based on, indeed, the experience of my department, of myself, but also on a thorough review of the recent literature. You said that in case of a blunt trauma, on average, when someone experienced a blunt trauma, the risk of a cervical spine injury is more or less 3%. And what is really interesting is that currently in Europe, at least, 2/3 of the cause of cervical spine injuries are related to motor vehicle accident. It's the main cause of cervical spine injuries, unfortunately. And you see that the main mechanism of cervical spine injury during a MVA, motor vehicle accident, is a whiplash problem. So the first question, when you think that there is a cervical spine injury, is it unstable or not? And so the first step will be to immobilize your patient. Regarding the clinic, you know that there is a bimodal age distribution. We have to analyze the existence or not of a spinal cord injury, and you will also to analyze the existence of a vertebral artery injury. The bimodal age distribution is more or less 20 to 30 years of age and after 65 years of age. Regarding the possibility of a spinal cord injury, you know that there are 5 main clinical syndromes: a posterior syndrome, central syndrome, anterior syndrome, lateral syndrome, and unfortunately the most severe, the severest, is the transection. All these syndromes are the association of essentially 3 types of clinical signs: protopathic proprioceptive or epicritic dysfunction, motor dysfunction, of protopathic dysfunction. It is a combination of these 4 main types of clinical syndrome in the spinal cord syndrome. There is so far a controversy regarding the use of steroids, but if you use the recommendation of the RO organization, the RO organization guideline is if you can give steroid within 8 hours, they recommend to give high dose methylprednisolone followed by a 24-hour infusion. Is the RO guideline, but there is controversy in many papers, even if many papers support experimentally the use of steroids. Regarding the vertebral artery injury, you know the position of this vertebral artery on both sides of the cervical spine, and you know that in 1 in 5 of cervical spine injury, they will have a vertebral artery injury. and in 80% of the cases, the lesion of the vertebral artery will be at the level of the upper part of the cervical spine. On the other side, what is really interesting is that there is only 0.9% of clinical expression of a vertebral artery injury under the form of a posterior stroke. That means that if there is a vertebral artery injury, in most of the cases, you won't have a clinical expression of that injury. You see here, in case of a wrestling accident, one of these two guys developed a subluxation. This subluxation was first reduced by traction and then an anterior cervical decompression and fusion. But for a reason of medical, legal, and insurance reason, the surgeon who take care of that guy performed angiography and observed a stop of one vertebral artery without clinical expression. So that in most of the case, performing an angiography is not really useful, but in this case, because there is insurance which can pay the patient for that problem, that angiography has been performed. Next step, the radiological workup. The radiological workup in my country is essentially based on CT scan and MRI. And we use the Iospine classification, which is more and more present in papers and in different congresses. The Iospine classification will be based on the clinic, on the morphology, on the level interested considered by the trauma, and the existence of a few modifiers. First, the clinic. The Iospine classification used this type of scale. N0, the patient is neurological intact. N1, that means transient neurological deficit. N2, radicular symptom. N3, incomplete spinal cord injury. N4, complete spinal cord injury. And X cannot be examined. And plus, that means continued spinal compression. It's the clinical scale of the Iospine classification. Regarding the morphology of the Iospine classification, there is an algorithm based on three main mechanisms which clarify very beautifully the classification of the spinal, the cervical spine injuries. You will see that immediately. There is three main mechanisms: translation, distraction, and compression. You have to start all the time asking yourself, there is first one translation. Translation is very severe condition, and it will be a C fracture, C problem. And then you will go for the tension band injury, the ligaments. And if there is one, and especially the anterior band injury, the severest in that group, it will be a B, and especially a B3. And if there is a compression, the third question, compression, especially of the posterior wall, which are the severest situation, it will be A4, A3. So C, B, A. The Iospine classification distinguish classification for the upper cervical spine injuries and the classification for the subaxial cervical spine injury. Which interesting is that when there is a cervical spine injury, you know that the two vertebrae, which will be the most injured will be C2. In 38% of the cervical spine injury, C2 is involved. And in second position, it's C7, 32%. Third position, C6. Fourth position, C1. In 20% of the cervical spine injury, C1 is involved. But there are, in 40% of the cervical spine injury, more than one vertebra which is involved by the trauma. And there is a very interesting paper which says, if you have a C2 injury, there is a 25% of having also a C1 injury. If you have a C7 injury, you see that you will have a risk of more than 30% of having a C6 injury. If you have a C1 injury, you have nearly 50% risk of having also a C2 injury. If you have a C6 injury, you see that you will have a risk, a very high risk of having a C7 injury. C2, C1, C7, C6, you see that if you see an injury of a vertebra, you have to examine very carefully the proximity of that vertebra. Regarding the upper cervical spine, C0, C1, C2, that level is involved in 2/3 of the cervical spine injury. You see C0, C1, C2, but especially C2 are involved. And always you will have to think translation first, ligament second, and the third one, sorry, only bone, compression bone, and that level is most of the time means a conservative treatment. Look now at the most involved vertebra by a cervical spine injury, C2. The axis, we use the Iospine classification system, and we will distinguish the endotoid, the pars interarticularis, and the disc. Again, translation, ligament, bone. You see here the translation is a very severe situation. The PIA is fracture. You have the disc fracture. It's translation here, PIA and disc without translation, and there only bone without translation, without ligament involved by the trauma. 2/3 of the fracture of C2 are fracture going between the endotoid and the body of C2. 1 in 5 will involve the PIA, the pars interarticularis. First, the endotoid. There is also a very famous classification in addition of the Iospine classification, is the classification of Anderson and Alonso, and that's the name. That kind of fracture, the most frequent, type 2, a fracture between the endotoid and the body. Type 3 is a fracture through the body of C2. And we have here 2 classical examples of a type 2 endotoid fracture, and here a type 3 going through the body of C2. The treatment, conservative versus surgery. The most frequent fracture is type 2. There is a controversy. It's a very, very interesting. There is a very recent paper published in Neurosurgery regarding the conservative treatment of type 2. Conservative with a rigid collar or semi-rigid collar in older people older than 65 years of age. And these authors have observed no statistically significant difference in pain, disability, length of survival between patients who achieved union and those with non-union. No difference between these two groups in older people. Interesting, very interesting observation. So the semi-rigid collar during 12 weeks is possible. You have also the hollow vest immobilization, but this kind of treatment have a high rate of complication, nearly 50%. And there is a higher mortality for people, for older people. So you should have a careful discussion before using the hollow vest. Third, you have the anterior undotoid screw fixation with visualization of the junction of C2, C3, with more modern technique without visualization of the C2, C3 junction. Rate of complication 6%, fusion rate more or less 88%. You will see here a very nice meta-analysis with more than 2,000 of patients. And you see that the rate of bone fusion is more or less 88%. And you see the different kind of complication, screw malposition, 1.5%, screw cut out, 2.4%, screw loosening, 1.2%, more or less 6%. And of course, some people will use one screw, and other people will use 2 screws. The fourth technique is a very elegant one, is the C1, C2 posterior fixation with a fusion rate of 95%, very stable fixation. And you see screw in the lateral mass, screw in the pars interarticularis of C2. The approach is a little bit difficult, but you know the anatomy of that area, with especially the care that you will have for the vertebral artery going above the posterior arch of C1. You know that if you want to put screw in the pars interarticularis, there is some orientation, 35° to the midline, 38° upward. But with the technology, and especially with neuronavigation, the possibility of placing screw in the lateral masses or in the pars interarticularis have been augmented. And in addition to that neuronavigation, we also have a robotic zygo, which is a kind of CT scan, which help us to perform in time neuronavigation and also intraoperative control of our screw placement. You see a case with the placement of the screws, and if it's a young patient who wants to recover completely the mobility of the upper cervical spine, you remove the screws. Of course, the risk of having a non-union increases with the gap between the 2 parts of the bone, and when the gap is 3 or more millimeters, there is a higher risk of non-union. pars interarticularis now involved in 1 in 5 of this kind of fracture. I would like to stress the difference between the pars interarticularis and the pedicle of C2. They are regularly confused. The pars interarticularis is really between the superior articular surface and the inferior articular surface. You see the position of the PIA compared to the pedicle. The pedicle is between the body of C2 and the PIA. Again, position of the vertebral artery. And in addition to the Iospine classification, some people use the Levin-Edwards classification, but I will stay with the Iospine classification, which is very useful. And again, you see translation to compression, translation, distraction, compression. Here, the Lewin classification, to show you a few examples. The most severe case is Lewin 3. That means you have PIA rupture and translation of the body, very severe complete case. Lewin 2 is the typical hangman fracture with PIA fracture, disc disruption, and a displacement of the body upward and backward. It is typical that kind of accident, motor vehicle accident, with the face of the patient going into the screen of the car. And you will have, of course, face injury. Also typical of old people using a bicycle and falling down on the chin. Another very special case is the type 2A, where the body of C2 goes forward. And there is a very interesting paper of paraglider we have a very rough opening of his parachute, and the movement caused a brutal movement of his head below, and unfortunately, this patient experienced PIA fracture with subluxation of the body of C2 forward. And type 1, the less severe case of PIA fracture. In such case, we will perform a surgery anterior cervical discectomy with fusion, ACDF, anterior cervical discectomy and fusion. And you see that this ACDF with an anterior plate, we can recover the position of the body and the endotoid of C2 by a careful placed implant between C2 and C3. For that, you can use human bone allograft. It's what we do in my department with a cervical plate. For that, we use bone coming from bank of bone from the talus, and this kind of allograft is very efficient, associated with an anterior plate. In less severe case, we use a Roissy cervical cage with vertebral plating technology. You have here the Roissy implant with some kind of ceramic to replace the autograft. Is less aggressive, and you see here the vertebral plating technology, also very efficient. in less severe case. Now the C1 level, the Atlas. Again, we use the AOSC classification, but there are other classifications, and especially the Jefferson classification. But again, we need to unify our analysis of cervical spine injury, and the best way would be to use the Iospine classification. For C1, again, always the algorithm with the three main mechanisms: translation, distraction, compression. You see here, distraction, ligament rupture, here, bone rupture. Here for the ligament compression, we look at the transverse atlantal ligament, which is the horizontal part of the cruciform ligament. And there is the Spence rule, which said that when the translation of the lateral mass of C1 is equal to 7 or more millimeter, that means that we are in presence of an unstable fracture. 1 in 3 of the fracture of C1 are fortunately that kind of fracture of the anterior arch and fracture of the posterior arch. No dangerous fracture which can be conservative managed. Again, to remind you that when you have a C1 fracture, in more than 50% of the case, you will also have a C2 fracture. That means there is a strong relation between C1 and C2. For C0, I mean the occipital condyle fracture, again, the Iospine classification, again, the algorithm, translation, distraction, compression. Now, the second level of the Iospine classification is the subaxial cervical spine. And at that level, it is essentially C7, which is involved. And very frequently processes, it's not important, and facets. You see here the Iospine classification for the subaxial level. Again, the algorithm, translation, distraction, tension band injuries, compression. Translation, very severe. Tension band injury, and in particularly the anterior band injury, the most severe in that group, and compression, and the most severe, the posterior wall fracture. But we will interest ourselves especially to these two new types, which are characteristics of the subaxial level. It is the type F, facet injury, and the bilateral injuries. So facet injury, the F type in the AOSC classification. Again, the algorithm is translation, distraction, compression. What's interesting is in case of unilateral, non-displaced facet fracture, the bracing conservative treatment is efficient in more than 83% of the cases. In case of non-efficiency, in 1 in 3 cases, it will be because of a floating lateral mass. You see, a floating lateral mass. When there is a displaced fracture, you can perform, the reduction will be reached by a simple traction in 50% of the case, and in the other 50%, it's during an anterior intraoperative procedure that you will be able to reduce the displaced fracture. You have here an example of, you see that on the sagittal view, the fracture is not well visible, except here. You see the posterior part, but actually it is a floating mass. Anterior fracture, posterior fracture, and this person developed a few days after that fracture, that subluxation of C4 on C5, and thus was operated with an ACDF. Regarding the bilateral injuries, BL in the Iospine classification, they are very often severe injuries. You see, you have to check, especially with an MRI, the existence of a disc herniation, which is a modifier in the Iospine classification. And in such a case, you have to first perform an ACDF and, if necessary, a posterior fixation. The AOSC modifiers, they are important because they help you to better take care of your patient. Modifier 1, posterior capsuloligamentus complex injury. Modifier 2, you have seen that critical disc herniation. Modifier 3, all the stiffening metabolic bone disease, hyperhostosis, ankylosis, ossification of PLL, ossification of the ligamentum flavum are modifier in the strategy to take care of your patient. Modifier 4, the vertebral artery abnormalities. And now I would like to slowly conclude, stressing something very important. You see here the spinal surgery adverse events, SSAE. There is a spinal surgery adverse event in 20% of the cases, even if the patient is operated in a level 1 traumatic center. The level 1 traumatic center in USA and in Europe, in USA, are the highest level of taking care of a patient with a cervical spine injury. And even in such high trained center, you see that you will have a spinal surgery adverse event in 20% of the cases. So cervical spinal injury, especially with the spinal cord problem, are very difficult cases to be taken care. You see that very recent paper showing a 22% rate of a spinal surgery adverse event, and you see, for example, 7% of insufficient spinal decompression. There are even a 2% rate of new spinal cord compression by the surgery. These cervical spine adverse events are bad for the patient, of course, because there is an increase of second complication. There is a decrease of the quality of the neurological outcome. There is an increase of postoperative dysphagia and also a big increase regarding the cost of the care of the patient. So I would like to conclude regarding the cervical spine injury which these two are the main location of the problem. Unstable, immobilized, use the Iospine classification. It's a very nice classification and it will help us to speak between each other. And you see the main strategy, color, traction, allo versus fusion are the basis of the treatment. And please, the expertise of the people taking care of this kind of injuries are paramount. Thank you for your attention.
Thank you very much, Professor Rastopoulos, for that wonderful and enlightening lecture, especially for the young neurosurgeon about the cervical spine injury, especially focusing on C1, C2, which is very important topic for the young neurosurgeon. Now, may I request Professor Alexander, the president of Ukrainian Neurosurgical Society, and after that, Professor Fawad Pirzad, who is the president of Afghanistan Neurosurgical Society, to make few comments about Professor Rastopoulos' presentation, and also tell us about the status of how you handle the cervical spine injuries at your countries. Professor Alexander, you first. You are muted, Professor. You have to unmute.
I'm unmuted. Can you hear me?
Yes.
Yeah.
Please go
Okay.
ahead.
Okay. So thank you very much for a very nice presentation. First of all, I want to say that now we meet a lot of combat trauma. It's a little bit different from the trauma of normal situation. We have more penetrating injuries, more severe injuries, high velocity injuries, and of course the prognosis in this patient is also not so good. Concerning the general practice in Ukraine, I want to say it's actually we use the same protocols that I used in Europe and in the world. So maybe so in my clinic we are maybe more conservative in general, especially in cases of stable trauma. What to say? I want to say that actually I completely agree with the professor with everything he told, and I cannot add anything more. So thank you very much. So thank you.
Thank you. My pleasure.
Thank you, Professor Alexander. Professor Fawad Pirzad, are you there?
Yes, thank you very much.
Yes.
Thank you, Professor, for excellent lecture. It was very useful for us, for our young neurosurgeon. And also, I would like to say hello and thank you for Professor Christine. You know your situation. We have sympathy with you, with your people. We feel that's the war in Ukraine, and we are very sad about this. You know, we feel your situation. That's we also in a war nowadays. Unfortunately, last week we have a lot of explosion in the schools, and we have a lot of injured people and killed. Unfortunately, our people during this explosion, suicide bomber, and this was excellent lecture and presentation. Thank you very much. And we, as I told you, we have a lot of cases of. May I share my screen? In the future, I will have a presentation about trauma in Afghanistan. If you like, we do. Hello.
So we cannot see your slides.
Professor Pizat, are you showing your slide, Prof?
Sorry, I will show in another. I will make a presentation in the future. Just I like to show you that last week explosion we had a young boy with cervical spine injury, and also we had another lady with cervical spine, and we operated on her, and she is going better. But as Professor told, that's but good situation and good equipment. It's very good outcome. But unfortunately, in our situation, it's but low resources or not resources. It's, we are facing with difficulties in Afghanistan.
Thank you, Professor Pizat. We hope we'll be able to see the images in the next session.
Thank you.
Any question from the other panelists?
So Christian, thank you very much for a nice lecture. So I think that lecture is one of your favorite, the area. And just I want to know, because you mentioned about the complication of the hollow vest, about up to the 50%. So what is the reason, or what kind of the complication with the hollow vest?
But there are many types. To start is the possibility for the patient to support it. There are a few patients who will say after 2, 3, or 4 weeks, I cannot go with the hollow vest anymore, I'm getting crazy. Another complication is, for example, the pin into the skull. The pin will start to move. Another complication is the pin infection with the pin. Another complication is the compression of the vest against the skin with apparition of a scar. Another complication is the patient who cannot move easily and will fall again with the hollow vest. There are a lot of potential complications. Is the reason why if we go for a hollow vest, because it's a very good technique, in many hospitals, in many centers, they are very, and we use it, but we have to discuss with the patient. The patient must be, the best is a young patient, and the patient must understand that his life will be very, very special during at least 3 months.
Thank you. Thanks so much.
There is a question, Professor, in the chat box. Probably I can convert it into the other way of asking. What do you think that, is it safe to do a cervical spine injury via a C-arm?
I didn't understand.
No, because it's written here, some places in his country do not have C-arm. So do you think that any possibility to do any cervical injury surgery via a C-arm?
I think we have, every one of us has to be his best with what he has. Fortunately for me, I have also wonderful machines, but the best thing is still the surgeon and his experience and the way will be performed a careful surgery. Of course, having a C-arm in the OR, and especially a robotic C-arm, is probably will ease the surgery and will increase the security for the patient. But we have, in every part of the world, we have to do with what we have.
I have one question, Professor. I want to find out how safe is to do a skull traction for a jump facet in a comatose head injury patient. How do you make the decision?
It's a very interesting question. We will do that only after an MRI.
The
If
MRI, yes.
we
Please.
perform the MRI, and based on the MRI, we will see the degree of security of performing a traction without the patient being awake. So MRI is really important.
Regarding the MRI, Professor, how do you decide if there is an injury to the anterior longitudinal ligament and posterior ligament? How do you decide which are safe for traction, Professor?
I think it will depend of the combination of the CT and MRI and the mechanism of the trauma. If it's a flexion trauma, extension trauma, and on the MRI, on average, it's very easy to identify the probability of a ligament trauma.
Thank you, Professor.
A great pleasure.
Any question from you?
Thank you very much, Dr. Liu. Thank you very much, Liu, and thank you very much, Professor Raftopoulos, for answering those questions. Any other question in the from the panelists? Yes. Yes, Professor Fawad Pirzad, I can see your hand raised.
Yes,
You want to say something?
Okay. Yeah. Just Dr. Ubaid Mujaddi asked, he is one experienced, our colleague from Afghanistan, and he asked the question that in public hospital, we haven't CR, unfortunately. And even in some hospital, we haven't a portable X-ray machine. And it's very difficult during the, to do open surgery. And just he likes to know your advice for how do freehand surgery for C-spine and poor country like Afghanistan.
Professor Fawad?
Yes.
Yes. Can you repeat your question, and whom do you want it to be answered?
Yes,
can you repeat it again?
Yes, I told that Dr. Ubaid Mujaddi, one of our colleagues from Afghanistan, he asked about in public hospitals, we haven't C-arm or portable X-ray machine. And what is your advice for how to do, how to deal with C-spine with freehand surgery?
Okay, Professor Raftopoulos, I will repeat that question for you.
Yes.
There are places, especially the low resource places, wherein the availability of C-arm is very rare. So in those cases, can you give us some tips of how to perform cervical spine injury cases without C-arm, with a free hand? Your comments, Professor.
I think that first you have to be very careful. The second point for me will be you have to be even better clinician and better analyze the situation of your patient. Third, you can perform conservative treatment, and you will perform on average more conservative treatment. You are obliged, if you cannot operate the patient, you will be conservative. And if you do, and you can perform very excellent conservative treatment as well, based on traction based on the clinical syndrome of the patient, and the quality of the bracing that you will have. Not being able to perform open surgery does not mean that you cannot help your patient with a good clinical analysis and a good conservative treatment.
Thank you. Thank you very much, Professor.
Thank you.
We have a question, hand raised by Dr. Ben, who is a young neurosurgeon committee member from Hong Kong. Yes, Ben, please go ahead. Please ask your question.
Yeah, hello everyone, and I'm Ben from Hong Kong, and thank you, Professor, for your excellent lecture. May I ask, in your center, how would you usually classify vertebral artery injury from trauma in a daily clinical basis? And may I ask, how would you treat the or I would better to say to prevent stroke using an antiplatelet or endovascular therapy in your center? If the antiplatelet, the medical treatment is used, usually how would you monitor, and how would you, what's the duration of the antiplatelet therapy in your center? Would you do a follow-up imaging to see if the, for example, dissection has resolved or not, to decide on the duration of the antiplatelet? Thank you, Professor.
Okay. As you know, there are two kinds of problems there. A very frequent problem is interruption of the vertebral artery. Interruption without any clinical sign is the most frequent. And in such a case, we cannot perform, we won't perform anything. We will follow up the patient. In case of vertebral dissection, the first treatment will be antiaggregant, and we will follow the patient clinically first, at least at the beginning once a week and after once a month. And for medical legal reason in Belgium, we will perform an angiogram after 3 months. But again, our decision will be based on a clinical follow-up.
Thank you so much.
Thank you. Thank you very much, Ben, for active participation. May I request, we've got two interesting guests, Dr. Dilshad Mamad Aliyev and Dr. Maruf Matsumayev from Uzbekistan. Dr. Dilshad is also a member of our ACNS-YNS committee, and he's ex-fellow at Fujita Health University, who was trained under Professor Yoko Kato. May I request Dr. Dilshad to please say a few words, and can you make the announcement of your Neurosurgical Congress? Dr. Dilshad, are you there?
Hello. Yes, I'm here.
Hello.
Hello, everybody.
Hi.
Thank you so much. Hello.
Hello.
Hello, professors. Hello, Professor Yokokato and Professor Raftopoulos. It's nice to meet you here. It's a nice tradition of ACNS inviting all young neurosurgeons and providing this kind of webinars for everybody throughout the world. And we, as practicing neurosurgeons, young neurosurgeons, very glad to have these kind of webinars. And we support this. And I want to invite you all to our coming third Congress of Uzbekistan Neurosurgeons. It is going to be in Samarkand city, which is one of the ancient and big cities of Uzbekistan. And maybe you all know this city. And as usual, we have invited all our old guests. I mean, the old previous scientists, neurosurgeons, which were participated in our previous congresses. And this time, because of this pandemic situation is still going on, and the Congress is going to be in hybrid format. So if anybody from you who can join us and give a reports or presentations in his specialty, you are most welcome, and we can add your presentation to the program, and maybe we can do this kind of discussions in the Congress also. And Professor Yoko Kato is already has her talk there. And at least you are going to be attendees, and we will be glad of this. Thank you so much.
Thank you, Dilshad. All the best for your Congress.
Thank you. Thank you very much, Dr. Dilshad, and all the best for your Congress. Dr. Maruf, are you there? Because you've been there since the beginning. I can see your name.
Hi, Maruf.
Hello, everybody.
Hi. Hello. How are you?
Fine, thank you.
Thank you.
Hi. So would you like to ask some question to Professor Raftopoulos, or tell us about how do you handle cervical spine injuries at Uzbekistan?
No questions, and thank you for your presentations. Thank you.
Okay, thank you. Thank you very much. Thank you for participation, Dr. Maruf. Dr. Pui Che, are you there, Dr. Pui? She's one of our recently joined young neurosurgeon.
Yes, I'm here.
Yes, can you introduce yourself and you can ask a question or a doubt if you have anything?
Yeah, thank you. Okay, yeah, thank you for inviting me to join this webinar. Yeah, for today, I do not have any questions, but this is a very interesting talk and very informative for all the young neurosurgeons. Yeah, especially in countries like ours who have a very high volume of trauma cases. This is a very informative talk. Yeah, thank you, Professor.
Thank you for participation, Dr. Pui. Please continue participating. Thank you very much.
Yeah, thank you.
Yes. Now, before we go for the second talk, I've got one last question. Since we're discussing about the problems of doing a cervical spine cases in a low setup or low resource scenario where even the C-arm is not there, I've worked in a setup in Apollo Hospital, Chennai, which is one of the corporate hospital in India, and there we had a robotic arm. So we used to manage certain cases with the robotic arm and robotic screw placement. What is your opinion, Professor? Because as you were mentioning about the complications or the adverse effect, even in the high-end centers are quite high. Do you think this high-end technology like robotic arm can reduce these complications? Or what is your opinion, Professor?
I think that robotic placement are very, very high level of security for the patient. But I think that when you have neuronavigation, you will have the same result as a robot.
Robotic.
Because you use neuronavigation. The robot is more automatization. I think it's very, very expensive to use a robot. What's the plus point of a robot? It's difficult to say. I say a robotic arm. It's probably more automatic, but the cost effectiveness is still low. It's the reason why for example, we have recently for epilepsy to place electrode, a semi-robotic system, because the robotic system are very expensive and do not give so much for the price. Whenever you have neuronavigation, you have enough to reach the highest level of results.
Thank you. I agree totally with you, Professor. I think navigation gives you and even the freedom of your putting a screw, because with the robot you are stuck with the direction what robot is giving you, and you don't have any sense of freedom.
Exactly.
Correct. Yes. Thank you. Thank you very much, Professor. I think we'll move ahead with our second talk. So, as the protocol of our webinar, we've got the guest speaker and we've got the YNS speaker. I would request Professor Christian Raftopoulos to be with us and participate in the YNS talk and the discussion session also. So certainly. I have yes, Professor. I have my co-moderator, Dr. Jiao Chen from China. May I request Dr. Chen to kindly introduce Dr. Zhu Feng for his talk, Dr. Chen?
Okay, thank you so much. I'm honored and humbled at here introduce my my colleagues in Shanghai. He's a rising star working in Shanghai Fudan University Subaxial Hospital. Yeah, he's a MD and a PhD. He was a school-based fellow in Department of Neurosurgery, Neurosurgery University Hospital, Kensey Medical Center. He was also a visitor fellow in Barrow Neurological Institute and Arkansas Neurological Institution. He has much publications, totally 63, include a co-author and co-first author. And he's also reviews in 7 medical journals, especially in neurosurgery and neurosurgery review and general clinical neurosurgery science. Okay, next, let's welcome his presentation. Please, thank you.
Thank you, Dr. Chen.
Yeah.
Wait a moment. Is that okay?
Yes, we can see it. Please go ahead, Professor.
Yeah. Okay. Good evening. Thank you for invitation and give me the opportunity to be here, be a speaker. So my name is Xu Feng, and I came from the Department of Neurosurgery Huashan Hospital, and Dr. Xu Bing, and I was in the same group. So the topic of my presentation is surgical clipping of the periclinal aneurysm in the stent fluid diverter area. So the periclinal aneurysm is defined as the aneurysm arising from the segment of the ICA between the distal ring and the original of the Pedicle artery. So it's also called ophthalmic segment aneurysm, proximal ICA aneurysm, or ventral ICA aneurysm, or sometimes carotid cave aneurysm. And according to the classification of the ICA, is divided into the 7 segments, and ophthalmic segment is the C6. This is a lateral view of the ophthalmic segment of the ICA, C6. And in our center, in our group, we can perform both endovascular and open surgery. So with the development of the embolic material and technique, the endovascular treatment has become the first choice. For small and medium size, we usually use the stent-assisted coiling. For large or giant aneurysm, fluid diverter is preferred. And if there are some indications or economic factors, the surgical clipping is also an alternative. And bypass is the last chance. And the stent included the lesser cart, such as Enterprise and Neuroform Atlas, or braided stent, such as Elvis or Leo stent, and all these small and medium aneurysm were treated well with the stent assist coiling. For the tandem intracranial aneurysm, we usually use the fluid diverter And the pipeline is in American, and the tuberage is in China. And for some aneurysm, the partial coiling or density coiling is adjunctive. And nowadays in our center, the indications for surgical clipping included the multiple intracranial aneurysm, not tandem, the peptic ulcer, antiplatelet allergy, a large sac on narrow neck, and a jet sign, economic factor. And the most used classification of the pericardial aneurysm is Brahmi classification. It's divided in type 4. And the type 1, divided in type 1A, type 1B. The type 1A arising from the superior ophthalmic segment of the ICA and are related to the ophthalmic artery. It's projecting either medial or lateral to the optic nerve and projecting superiorly. The type 1B had no relationship with the branch. And the type 2 is located at the ventral surface of the ICA. And the type 3, the type 3A is related to the superior hypophyseal trunk and is projected above the dorsum sella, projected medially. And the type 3B projected medially infradiaphragmatic, is arising from the medial surface of the clinoid segment of the ICA. The type 4 is included the clinoid segment and the ophthalmic segment of the ICA, the aneurysm is wide neck. So I will show some intralateral cases. For type 1A, we call the ophthalmic aneurysm. This is a 44-year-old female suffered vision decrease in the left eye. It's a ruptured giant pericardial aneurysm, but from the DSA, we can see the large sac and the narrow neck, and also have the jet sign. So the fluid diverter is not the first choice. We recommend the open surgery and expose the cervical ICA. After removing the ACP, we used two clip to clip the aneurysm, and the aneurysm body was also resected. The ICG demonstrates the patency of the ICA and the aneurysm obliteration. And this is a video. And we dissect the severe fissure from the distal to the proxima. And we open the carotid system. For this type of the aneurysm, the lateral aspect of the optical canal was removed, and the medial aspect of the subpartial of the anterior client process was removed. A high-speed air drill was used to remove the anterior clinoid process. Now we are removing the medial aspect of the ACP. Here, sometimes a sharp dissection is needed to remove the ACP. So, and then we open the falciform ligament and the distal ring to expose the proximal aneurysm neck on the schizza. We temporarily occluded the A1 and the Pedicle artery and the cervical ICA, and to expose the distal neck, the proximal neck, and a straight clip was used to parallel to the ICA. It's pilot clipping. And the temporary clippers were removed, and so ICG confirms the complete obliteration. As we puncture the aneurysm and shrink the aneurysm body. And this is the right optic nerve. And we use another clip to tandem clipping and resect some part of the aneurysm body. This is optic chiasm. A post-operative, the patient recovered well and his vision is improved. And this is another case. It's a 56-year-old female complainant of the intermittent headache, was admitted in 5 years ago. At that time, the flow diverter is not available, so the patient was treated in the hybrid operating room, and we used a double lumen balloon guide catheter was placed in the right ICA, and use a retrograde suction decompression technique to clip the aneurysm. And this is a immediate angiographic result. And this is 5 years later, the follow-up angiography showed no obvious recurrence. This is also a large paracardial aneurysm type 1A. Because of the economic factors, we used 2 clips to clip the aneurysm. With type 1B, for this patient is a 70-year-old female, and it's 3 type aorta arch and tortuous of the ICA, and also the economic factor. The DSA demonstrates a right large paracardial aneurysm. The compressed test shows the good collateral circulation from the anterior circulation or posterior circulation. So we also used 3 straight clips to parallel to the ICA to clip the aneurysm neck. And this is ICG, also recovered well. And this is the video, intraoperative view. For this type of the ophthalmic aneurysm the key point is removal of the ACP, especially the lateral and the posterior segment of the ACP was removed. See the lateral aspect. And the distal ring was opened widely to expose the proximal neck and the plane between the cavernous sinus roof and the aneurysm founders. The plane should be dissected clearly to expose the proximal neck. And first, the pilot clipping is also used as straight clip. For this kind of the large or giant aneurysm, if there is no hybrid operating room, the retrograde suction, such as the Dallas technique, is very useful. And last, the dog ear, we use another clip. And the patient is a 60-year-old male complaining of the headache because of aspirin allergy. So we use the open surgery to treat the aneurysm. The post-operative CT shows the patency of the stenosis of the ICA and obliteration of the aneurysm. It's also a 52-year-old male presenting with dizziness. The patient had a peptic ulcer, so we also treat using the open surgery. It's another case. Use a perpendicular clip, and this is a ruptured the I type 1B, the larger aneurysm. Because ruptured joint periclinoid aneurysm sometimes is not suitable for the fluid diverter, so we use the craniotomy to treat the patient. Also recovered well. And the type 2 is located at the ventral surface of the ICA. This is a 65-year-old female and found the multiple intracranial aneurysm during examination. It's a middle cerebral MCA bifurcation and it's a Pedicle, and also find the periclinoid aneurysm. We use a fenestrate, the angular fenestrate. This is the post-operative DSA, confirmed totally cure. Also another is a 55-year-old female, a recurrent aneurysm after coil embolization. Uses a perpendicular fenestrating to reconstruct the ICA. For the type 3A type is related to the superior hypophyseal artery. The 49-year-old female complained of the intermittent headache because of economic factors. The patient received the craniotomy. The operation is performed also in the hybrid operating room. Use the double lumen balloon guiding catheter. 3 perpendicular fenestrated clips were used to reconstruct the ICA. This is a post-operative DSA. This is a video. The severe fissure is also dissected in a, from distal to the proximal fashion. For this type of aneurysm, I think the anterior clinoid, the extent of the remove of the ACP is dependent to the aneurysm neck. Sometimes just little drilling. We use the CUSA. This is a CUSA, and only maybe you what you needed to do to unroof the optic canal. This is the most important. Optic canal should be removed. And as a falciform ligament was open, and the distal ring. And we elevating the optic nerve to expose the proximal. I think the first clip, the fenestrate clip, is most important because it was used to reconstruct the ICA. If there is not too much, will be aneurysm residual, but too much will result in the stenosis of the ICA. Okay, because of time limited. So we use a 3 perpendicular and also check the perforators were well, the ICG. Oh, sorry. And so another type 3A is a joint aneurysm. Before the operation, under the general anesthesia, the patient falling unconscious, so it's a ruptured aneurysm. We also perform the operation is a hybriding. Use the perpendicular, the fenestrate clip to reconstruct the ICA. Also the same. Another case. And this one use one fenestrated perpendicular and 2 curved clips to reconstruct the ICA. The post-operative shows no stenosis of the ICA. As a type 3B is because the aneurysm arising from the medial clinoid segment, the C5 segment of the ICA. So it belongs to the cavernous sinus, I think. This one we use the one fenestrated the perpendicular. This is post-operative CTA. And for some periclinoid aneurysm, the contralateral approach is also alternative. And this one, the patient, the right MCA bifurcation aneurysm and the left periclinoid aneurysm. And we use the right side approach, right superior optic approach, lateral approach. And this is the aneurysm, the MCA, and after clipping the ICG. And the aneurysm, the optical, interoptical space and I use one straight clip. This is after operative CTA. So I think the surgical clipping of the paracardial aneurysm, the key points is the individualized the anterior cardiodectomy and the extent of the cardiodectomy. I think the type 4 is most widely, and type 3B, type 1A, 1B, and then finally the type 2 or type 3A. The second key point is wide opening the distal ring and exposing the proximal neck. This is the most important, I think. And for large and joint aneurysm, retrograde suction, Dallas technique or in the balloon assisted is important. For the anterior cardiodectomy, there are two approaches. The one is intradural end block removal. And this is anatomy of end block of the anterior dectomy. And okay. And this is the actual dural anterior cardiodectomy is also, we know the modified Dolenka approach is epidural removal. So because of time limited, so I just only show some video. Okay. Also for large and giant paracardial aneurysm, the suction, decompression, or balloon assisted, I listed a table from the 1981 to the 2015. And balloon was placed in the neck, the cervical ICA, or the neck of the aneurysm office. So concludes, the clipping strategy for paracardial aneurysm depends on classification and the aneurysm size. So the clip application is used parallel to the ICA in type 1, whereas fenestrate clips are used frequently in type 2 and 3. A balloon-assisted retrograde suction decompression facilitates clipping on the large and giant paracardial aneurysm. So that's all. Thank you. This is our paper published in the World Neurosurgery. Thank you.
Thank you. Thank you very much, Professor. That was yet another very enlightening and especially on the difficult subject for the young neurosurgeon, not a routine clipping cases which you have shown. Dr. Chen there? Okay. Now,
yes,
so may I? Yes. May I request our discussant, Dr. Alexander from Ukraine, and then Dr. Fawad Pirzad from Afghanistan, to make few comments about the presentation of Dr. Feng and few tips for the young neurosurgeon about the clipping of paracardial aneurysm. Dr. Alexander first, please.
Okay, thank you, Dr. Feng. Thank you very much. First of all, thank you very much for excellent presentation, especially for very good video, which depicts the very good technique, surgical technique. Really, so thank you very much. I really enjoyed. What I want to say that you in your presentation you illustrated that surgery in the era of such repeatedly developing endovascular techniques, the surgery is not dying. So surgery is moving on together with endovascular techniques, and I think it's most effective way to cooperate with the invasive neuroradiologist and to develop the surgical technique, because surgery is not exhausted by itself. We develop the microsurgery also together with, and we work on, and we try to cooperate. We are cooperating together, and we can get the much better results in treatment of these patients. My question is, what would you do in patients with a pneumatized clinoid? Do you, when you have a anterior clinoid process highly pneumatized, and you can see it before surgery, what do you perform, the clinoidectomy, or you send patient to the endovascular?
Thank you for raising a good question. So for me, I'm open surgery, but at this time maybe for 90%, more than 90% of aneurysm, even 90%, I will choose the endovascular. So I think not too much aneurysm was suitable for clipping or any. All patients will choose the endovascular. So the first question. The second, and in our center for type 1, I'd like to use the intradural clinoidectomy. But the type 2 or type 3, maybe epidural, extradural, the clinoidectomy.
So my question was about the CSF leakage after clinoidectomy.
Oh,
Have you had the cases like this?
Yeah. It's good question. So at first I removed the first one, the patient. I remember 6 years ago. I used the en bloc technique. So the extent of the anterior clinoidectomy is too wide. So you should be careful to the sphenoid bone, the medial side. I think if the tailed anterior clinoidectomy, the more or less, I think, is enough to open the. I said the extent depends on the type of the aneurysm, the classification, and at last the UU technique or anything, the muscle and is to close the defect. I suffered one patient, the CFS leakage. One patient.
Okay. Thank you. Thank you very much. And I have one more remark concerning the cost of the endovascular. So, for example, in my country, people are not so well protected with the insurance, and not all of the insurance or government can cover the expenses for pipelines. It's too expensive. That is the reason that in my country we do more open surgeries. Not so many. Maybe we could discuss the pipelines, but it's too expensive for patients actually sometimes. So that is the reason, because we must rely on it, but not only in highly developed countries where the patients are secured by the government or insurance. We can do the expensive endovascular methods. For countries in the middle income countries and low, we must go on with the open surgery. That's true. That's the reality of our life. So that's my last remark. But in general, thank you very much. Thank you.
Thank you. Thank you.
Thank you very much, Dr. Alexander, for sharing your expert comments. May I request Professor Fawad Pirzad to make few comments about Professor Zhu Feng's talk and presentation, and tell us more about your experience of handling these kind of cases. Dr. Pirzad?
Yes.
Yeah.
Okay, thank you very much. Thank you, Professor Zhu Feng. Thank you for a nice presentation and nice video clips and operation. Congratulations. This was very good achievement. I'd like to know your opinion about what is your advice for timing of operation for ruptured aneurysm, and do you do EVD first or doing at the same time operation and clipping?
Rupture ophthalmic segment aneurysm. We usually it depends on the admission of the patient. We usually just 3 days. In 3 days, we so the time is not important. I think if you are ready, every time can craniotomy. But you say the EVD, we don't usually use the EVD before the craniotomy. If there is several hydrous, maybe we first place the EVD. This is our surgery timing.
Okay, thank you. And how to candidate patient for open surgery, for clipping, and for endovascular surgery?
Endovascular, I think the endovascular, yeah, you're right. The rupture, the aneurysm, the emergency, the endovascular is we should worry the risks of the stent use. Yeah, the acute stent use for assisted for the embolization, but we usually use it hyperized during the operation, the placement of the open after opening of the stent. We use the hyperized, and Cervical was used during the operation. So I think a rupture, we shouldn't wait for 3 weeks, or I think every time you are ready is okay. Don't worry about the risk of the stent use in the ruptured aneurysm. The risk, the complications, just a little bit increased, I think. Okay.
Okay, thank you.
Thank you very much, Dr. Pirzad. May I request Dr. Christian Raftopoulos to give your expert comments about Dr. Zhu Feng's talk, and some comments about your experience of handling this kind of cases. Professor Christian Raftopoulos.
It was a pleasure to listen to that presentation because, as you know, I like a lot surgery and vascular surgery, and the videos were excellent. And especially because in my country now, we give the patient the choice between endovascular and transcranial. And the indication of performing transcranial, especially for paracrinoidal aneurysm, are decreasing a lot. We keep transcranial surgery, we keep cleaning for young people most of the time. And even if there is less risk with clipping for a young patient, some young patient will choose endovascular surgery. So the situation is that endovascular surgery is 2/3 of the treatment and 1/3 of the treatment. In Belgium, when will we go for clip? There are 3 indications. First, when there is a big hematoma, the surgeon must go. The second indication is when the endovascular surgeon thinks that endovascular procedure is too risky. And the third one, as my colleague has demonstrated, is when there is a failed situation. That means the endovascular surgeon has tried to close the aneurysm and wasn't able to do that, there is a recanalization and we go for surgery. So there are three in my country now, the three only indication: hematoma, refuted aneurysm by the endovascular surgeon, of failed coil aneurysm after an endovascular procedure. And what I liked in the presentation of Xu is the bone CUSA. The bone CUSA is a wonderful tool to remove clinoid. It was very nicely demonstrated. I use that regularly when I have to operate such kind of thing. Well demonstrated. Thank you.
Thank you. Thank you. Thank you very much.
So can I ask the panel? Can I ask?
Yes.
Thank you very much for a nice presentation. I think just that you can explain, because many of the young neurosurgeon is listening. So what is the jet sign? And the second question is, what about the mass sign when the aneurysm protruding of the superior side, then compress the second nerve? And what about after coiling? So what about the mass sign, mass effect by coil?
Yeah. Thank you. Thank you.
And one more question is, what about the perforators? Can you keep the flow of the perforators with a stent or flow diverter? Because flow diverter is so mesh is dense.
Okay. So I said in our center, in our group, for large and the giant aneurysm, the fluid diverter is the first choice. I think the complete cure rate of the aneurysm is more than 90% use the fluid diverter. So make the treatment more easier. And the fluid diverter is the most is his advantage, but it costs too much, too expensive. In some cities, not under the insurance. And the jet sign, I think the jet sign is maybe in China. In China, we call the jet sign is the interflow. We just called it, and so just like jet intra-aneurysm flow in the neck. So for these patients, if you use the fluid diverter, the most dangerous complication is intrahemorrhage, post-operative intrahemorrhage. Even you use 2 or 3 or 4 fluid diverters, cannot eliminate the rupture risk. So for these patients with we call it jet sign. So I usually recommend the craniotomy to surgery. Just like the first case, I resected the aneurysm. And what about the second question? I'm sorry.
Yeah, the after coiling. So what
coiling,
about the, yes.
So for this, I said for medium or small size, we said it's smaller than 1 centimeter. Just the media or small. I think the braided stent, the Elvis stent or Leo stent, we need to place many coils. But for fluid diverter, maybe the large or giant and play 3 or 4 coils. It's okay. I think don't worry. And the post-operative follow-up angiogram is perfect. So I just say more and more endovascular treatment are used in our group.
So what about the perforators?
What?
Can you keep the perforators?
Sorry.
No, perforators.
Perforates. I'm sorry.
Perforators. Dr. Chen, can you explain to him, please?
Can you help me translate?
Perforator. Small vessels. less
Small
than 1
branches which
millimeter.
are
Perforators.
So when you place the stent or flow
Yeah.
diverter, can
Yeah.
you keep the flow of the perforated?
Small branches.
Perforate. How to spell? How to spell it, Dr. Kato?
What?
Perforate.
它是小血管的，小血管。
小血管对吧？
对
啊，周
Oh,
边那个小血管。
perforator. I'm sorry.
Yeah.
I'm sorry. Okay. So the flow diverter, I have used more than 200 fluid diver, maybe 100, more than 100 fluid diver. So don't worry about the perforators, such as the anterior choroidal artery or the posterior circulation, the Pedicle. Don't worry. And ophthalmic artery, don't worry. This is not the major problem. The flow diverter is often the perforator, such as the main trunk. If you place the flow diverter in the MCA bifurcation, so maybe the superior or inferior trunk were occluded at the follow-up angiography. But the ophthalmic artery in the publication or the literature review, I think the occlusion rate is less than maybe 2 or 3%, I think.
Thank you. Thank you so much. So it was an excellent talk. Thanks so much.
Thank you. I'm sorry.
Thank you.
Thank you.
Thank you. Thank you very much for your presentation. I learned a lot. And I want to use this a greater opportunity to ask you a case. My friend showed me a case. I feel it's weird. Let me show my, share my screen. May I show my screen? Yes. Okay. Can you see my screen?
Yes, we can see.
Yes.
Yeah.
This is I did a picture. It's a female, 7 years old, and the patient was diagnosed as with agrography in March. So you can see the aneurysm is here. The patient was conducted by stent. I think they use a stent at here.
Yeah.
Isolated for the aneurysm. But unfortunately, 2 days later, the patient got a hemorrhage at where?
A flow diverter. Yeah.
The patient used heparin after surgery, stent surgery. Only 2 days later, it's hemorrhage. The patient had a cranial surgery.
Oh, yeah.
Yeah, like this. My question is, what's the reason lead to the hemorrhage in the I think the aneurysm located at the right ICA, but hemorrhage at the left side. Usually, what's the problem with the patient? In your opinion?
Yeah. Thank you. Thank you for raising such a good question. So the remote hemorrhage, and or we can say the post-operative hemorrhage after the fluid diverter is a major complication we should concern for the fluid diverter. I think in our center we always perform the test, the antiplatelet, such as aspirin or another drug, the antiplatelet against. So to test if there is less inhibition or more this should be checked before operation.
Okay.
I think maybe 101%, the post embolization, the hemorrhage of the fluid diverter. Sometimes it cannot be avoided. Okay.
So this center operation was successful, but the problem is the patient's body may be allergic to the heparin, right?
Yeah, I suffered in our these patients. One patient suffered after the fluid diverter placement. Frontal lobe butt absorbed. It's lucky, no evacuation of the ham tumor, and absorbed. Observation just 2 weeks left the hospital.
Okay,
so lucky.
So this patient was bad lucky. I think her hemorrhage is severe and had to take operation to control the this bleeding. Thank you so much for your experience sharing with us. Thank you.
Thank you very much, Dr. Chen. I have one more question for Dr. Peng. What do you think, in your opinion, which are all the paraclinoid aneurysm cases in which the flow diverter or stent is not possible, but you would not do the clipping and you would prefer to do a bypass? What do you think, which would be that case?
Bypass, yeah. I think the bypass is joint or maybe 4 centimeter or larger than 3, and I think the tortures of the ICA and the wide neck, the neck cannot be clearly visualized, and I think the endovascular is possible. And for this patient, the intra or serpentine, I think the surgery is not amenable, so the bypass is the last choice for these patients.
Okay. Thank you, Professor.
Thank you.
I think the practice in the lab for the anterior clinoid drilling is very, very important for the young neurosurgeon if you want to try this particular kind of surgery. We need more and more practice in the lab.
Yeah.
Yes. Thank you, Professor.
Thank you.
Any other question? Dr. Ben, vascular neurosurgery is your favorite topic. Do you want to ask anything?
Yes, and for me, it's about for those with a ruptured aneurysm with a large hematoma. So my question of concern is that because it's quite during the because I always face with the difficulty in getting the proximal control for those large rupture paracardial aneurysm, even with anterior cranioidectomy. So can you share about your experience of those giant aneurysm? So how do you achieve a good proximal control, especially in the rupture cases?
Yeah. For the Oxamic, the artery aneurysm, and the epidural approach, such as the Dolenk approach, you can expose the cavernous sinus clinoidal segment of the ICA and to temporarily occlude the ICA. You don't need to expose the cervical ICA. But in my opinion, such as our Chinese, the Asian, more bleeding is the cavernous sinus. So if there is no gel form or we can say the liquid, the umbilical. So I usually expose the cervical ICA. I think it is the simplest. Or if you have the hybrid operating room, you can place a balloon. You don't need to expose the cervical ICA. Balloon inflated. And if you have the double lumen, you can retrograde suction the ICA. I think the Dallas technique, just to puncture the ICA, expose the ICA is the most easier to perform, to control, to complete the proximal control. You don't need to expose the cavernous sinus segment of the ICA.
Yeah, thank you so much, and really learn a lot from your experience in paracranial aneurysm. Yeah, thank you so much. 谢谢.
Thank you. 谢谢.
Thank you very much, Dr. Ben. If anybody has any doubt or any question? If not, then I would wanted to make one announcement before we take a winding up or a closing remark from the commentators and our chief Professor Yoko Kato. On 6th, 7th, and 8th of May, we're going to have one dedicated for the young neurosurgeon. This will be a 3 days dedicated webinar, which is for the young neurosurgeon, medical student, and neurosurgeon resident. So I request you all to kindly convey this message to your young neurosurgeons from your respective countries and ask them to kindly participate. There is a plethora of expert sessions we have organized, which they will definitely benefit from. After that, now may I request Professor Yoko Kato to make a final remark of today's webinar.
Well, thank you very much. The 2 talks was excellent, I think. So I don't think Dr. Penn is no more young neurosurgeon, I think, because you did so many pipeline. You said how many pipeline or flow diverter you experienced?
For me?
Yes.
Yeah, maybe 150.
Okay, so that is no more young neurosurgeon, I think. So anyway, the excellent talk. This, especially the question is, cervical is very popular, but I think we should learn a lot from the technique and also the technical, how do I say, some philosophical and also strategic the treatment of the cervical, the injuries. Thank you very much. And also today we had a very nice commentator, discussant from Ukraine and also Afghanistan. If you have time, please join us every time and give us some comments or discussion. Also, we want to invite more from Ukraine and Afghanistan, some other countries who lack of the chance of the study of the neurosurgery. Thank you so much.
Thank you very much, Professor Yogukato, for being so generous to offer any sort of help if it is needed in Ukraine or Afghanistan. Thank you very much.
Okay. So finish.
Thank you.
Thank
Yes.
you.
Thank you very
Thank you,
much.
John. Thank you so much.
Thank you.
Thank you.
Bye-bye.
Bye.
Thank you.
Bye.
Thank you very much.
Bye.
Thank you very much.
Bye.
Bye bye.
This short bye.